I'll be taking about a syndrome called Tumor Lysis syndrome. It's a medical oncological emergency. In this, what happens is like the tumor burdens are there, no? When this will lysate, so when it reaches the bloodstream, it will release potassium, phosphorus, and like uric acid, and like calcium levels. It will change. So how we can differentiate is like potassium will be high, greater than 6 milliequivalents per liter, and uric acid will be greater than 8 mg per deciliter, and phosphorus for children it's greater than 6.5 mg per deciliter in children, and like in adults it is 4.5 mg per dl, greater than or equal to, and calcium it is less than or equal to 7. So creatinine it will be side parameter which is increasing because of other parameters. So but what happens is like you can notice something changes. Like see, when you notice potassium, uric acid, and phosphorus, you can see there's a 25% increase in the baseline value. From the normal range, they have a 25% increase, and calcium where it's reducing by 25%. So how they diagnose this one is, even though it's like seen in cancer patients, mostly you can see it in any ALL, acute lymphoid, like acute lymphoid leukemias, and like CLL, or any Burkitt's lymphoma, like that few lymphomas you can see is. And wherever this like blood cancer, mostly you can see it in blood cancers, or like any tumors, like proper tumors there. These cases you can see. So it can be either caused by treatment. Either like when you give the chemotherapy, it can lysate because of the chemotherapy, because they're cytotoxic. So they'll this lysis will happen. Or else even when it's not getting treated also, it's like when the tumor is getting started to get like bigger and bigger, then also it will lysate. So these are the like 4 parameters mainly you have to monitor, and like creatinine it will automatically manage when you monitor these 4 parameters. In case not, we'll see them further management. So you can see hyperkalemia, where like potassium will be very high. Before that, I'll start like if you consider RBC, red blood cell, or any cells, tumor cells, you can see inside a cell potassium is very high. Intracellularly, potassium is very high. Extracellularly, you can see sodium is much more high. So as a cation, potassium is very high, and as an anion, phosphorus is very high inside a cell. And this is like DNA. You can see the DNA materials and everything. So you can see purines, pyrimidines, and other things in this one. So when this cell lysate, what happens is like this potassium, phosphorus, nucleic acid, you can say purines and pyrimidines, which will get released into the bloodstream. So what happens is like so that time hyperkalemia will happen. So we'll start with hyperkalemia, how we treat it, and how we clinically manifest it, and like how we treat it. So clinical features are like you can find cardiac arrhythmias beyond 6 and 5.5, 6 you can see, and like these are the some signs how like cardiac arrhythmias you can observe. Sinus bradycardia will be the sinus arrest, and slow intraventricular rhythms. The rhythms will be very slow. You can see in ECG waves, and prolongation of PR and QRS intervals. In ECG you can observe this one. So in ECG, mainly in ECG changes, you can see tall T waves from when the potassium value reaches 5.5 to 6.5. You can see tall T waves. It will be like pointed, very pointed T waves, like very high pointed. Like if you see some point, like it will very high pointed. And if you see loss of P waves, like beyond 6.5 and all, you won't see P waves. P is the starting one. So you won't see P, then you can see directly QRS. Mostly you see. And this is very mostly this is very commonly you can see. And like widening of QRS complex, and like where the this QRS complex is like it might actually normal ECG it might finish like this, but widening it prolongs too much. And beyond 8 it's sine wave pattern, and like these like in critically very critically ill patients you can see type 1 Brugada pattern. It's like sudden cardiac death and everything can occur in these cases. Critically ill patients you can see. So beyond that, management. So we manage this one in the basis of emergency. This is a hyperkalemia is a medical emergency compared to all other ones. This we can, still if it's increasing somehow we can manage. But potassium when it increases can cause cardiac arrest, kind of arrhythmias and everything. So there are 3 ways based on the how much it's increased. So if it's very high, way beyond high, you can use calcium compounds. So calcium compounds have a specialty that it like one second. it raises the action potential and like a threshold and like reduces the excitability without reducing the other potentials. So like so it repolarizes also. So that's how it relaxes the cardiac muscles and everything. So calcium gluconate we'll be using, one of the main compounds which you see in most ICU cases and everything. So 10 ml of 10% calcium gluconate. It will come around 1 ampule will come around I think 4 ml of calcium chloride, which have this 10 ml have. So it is infused over 2 to 3 minutes. With must thing is cardiac monitoring. You should do cardiac monitoring because it's very like potent one, like a very highly therapeutic and kind of very risky drug. So you have to keep on monitoring continuous cardiac monitoring, ECGs and everything. You have to continuously monitor. And its onset is very fast. That's the biggest advantage. So when it's high, we need to treat it very fast. So within 1 to 3 minutes, it will start acting, and it will last for 30 to 60 minutes. But in some cases, you will see it won't reduce that fast. So what will you do? We can repeat the same thing. We can repeat it one more time, but under supervision of cardiac monitoring still. And in case this I added as extra point, the digoxin and cardiotoxicity in like hypercalcemic patients. So that time like excess calcium will cause like toxicity again, and interaction also it will cause. So that time what they does is like 10% calcium gluconate plus 100 ml of 5% dextrose they'll add instead of the concentrated solution. So they'll dilute it in like in 5% dextrose in water, infuse from 20 to 30 minutes to avoid hypercalcemia. This is one method. And like second one is like rapid reduction of plasma concentration of potassium by redistributing into cells. So we already know that insulin does this better. So insulin 10 units we will give IV, regular insulins we will give. Why we give IVs have like a rapid action. If we give why like normally we will take subcutaneously, we have seen, but subcutaneously why it takes slower is like we have adipose tissues, fat layer cells. So it will release that insulin very slowly in an essential way, which is like, but we want it to treat it very fast. So we will give it as IV, along with followed by once after this injection, we will followed by we will give 50 ml dextrose, and its onset is from 10 to 20 minutes. It will act around like peak is around 30 to 60 minutes and last for like its half life. You can tell like 2 to 6 hours it will finish its action. So they'll repeat also sometimes based on emergencies. And like one other one is like cations. Cations they'll use like when its severity is very less. It's like you can say like slightly increase, means 5.1 to 5.5, like that range. When it's we see it very high, they start giving like you will see here what do you call it? Not adforce. No. This was one name. Suddenly I'm not getting. That's a sachet, K-bind sachet is. So that's a compound. So we'll give 15 to 30 grams in mannitol. Here I have seen like 100 ml of mannitol they'll be diluting and giving. So it acts over like 4 to 6 hours. Every 4 to 6 hours they'll repeat, maybe if it's needed, and it will work for 24 hours. It will give effectiveness. So after potassium, we see uric acid as little more severe condition. So it can cause gout and other issues, joint pain kind of things and all. So this will come when like we told about nucleic acids, the purines and pyrimids, when they like when there's in that metabolism you can see byproduct is like uric acid. So that cases you will see like a high uric acid beyond 8 and all. It's like little risky conditions. So there are actually 3 drugs, but mostly you will see like allopurinol, little more safer side compared to febuxostat. I'll tell you about that thing. They'll give 300 mg per meter square per day, or like in oncological conditions. This is like I'm talking about oncological conditions, or 10 mg per kg per day in 3 divided doses, maybe 100 mg, like 3 times they'll give, and maximum you can give up to 800 mg per day. So it is this is oral. Now some people can't tolerate oral, so that time they'll give IV. Any reactions or something they'll see. So that time they'll be giving 200 mg to 400 mg per meter square. So max dose you can see is about like 600 mg per day, maximum you can go. Now febuxostat doses usually from, these all are like xanthine oxidase inhibitor basically. So 40 to 60 mg OD they'll be giving. Some studies, some Chinese and some Japanese and some Indian studies, like some 2-3 trials was there. They recommend like 120 mg OD for duration of 14 days. This they'll be running for like they'll start from day 1 or day 2, and it will be continued to 3 to 7 days. They'll be continuing this one, and this they'll continue for 14 days mostly. And now raspberry case. This it's very lessly used. We don't see it. BBH I never seen it. It's very like in a beyond 10 and all, it's very high risk. You can see that cases they'll be using raspberry case. The one reason why they don't use it is it's very expensive. Somewhere it will come around, the cheapest one is coming around somewhere 7,200 something. So the original molecule is, which brand I forgot, it's around 14,500 something. So it's very expensive. One injection will contain somewhere 0.2 mg per mg per injection. That is a pre-filled injection. So high risk you will be giving 0.0 mg per kg OD. Intermediate will be giving 0.15 mg per kg, and low risk will give 0.1 mg per kg. But like if a patient is coming to you in emergency basis, so you don't know what to give. Like we are telling about mg per kg now. So by the time you calculate the VSA everything, like weight and everything, you don't know, like it will be costly again because we calculate the weight. Now the dose is increasing. So in that case, we will be giving 0.15 mg stat. This is stat dose we will be giving as initial zone. And like before coming to contraindication, I'll tell you one more added point. When this is an enzyme, kind of enzyme. This have it's an enzyme activity based on. So when you collect the sample, it should be freezed. It should be priorly freezed. At room temperature, it has still have action, so it will still catalyze. Keep on like catalyzing. So we won't get, like if you see the sample, if you test it, we will see like sometimes it will be less. Uric acid will be very less. See, for example, if I have 12, my uric acid. But when they take the sample, you will find it 4 also, 5 also, 6 also sometimes. But it won't reduce that fast. So what happens is actually it's still working at room temperature. So prior to the sample which we collect after raspberry case should be freezed and used within like 4 hours of the sample collection time. And it's contraindicated in the patients with glucose phosphate dehydrogenase because it's like it is one of the product is byproduct from this one is like end product is like urate oxidase. So it can't break. It is unable to break down the hydrogen peroxide, which is end product kind of which comes in the pathway. So it's contraindicated in those cases. Now coming to hyperphosphatemia, we'll be giving sevelamer 800 mg TID, and like this you can observe with the muscle cramps and everything. Muscle cramps like some spasms kind of things you'll observe, and main point is like how hypocalcemia is occurring because of phosphate is a calcium chelator. So when it's phosphate is binding to calcium, it will eliminate out the calcium which is sitting in the body. It will chelate and it will eliminate. So phosphate will be still high. It will get reabsorbed, but the calcium is getting eliminated. So that's how hypocalcemia occurs here. So calcium acetate, you have seen AdFos, I think, kind of AdFos kind of thing. This is usually you will give 677 mg here. You have seen in watts. So they'll give 2 times, just like calcium acetate. Then in case of hypocalcemia cases, there will be calcium gluconate only will give, but the difference is like we are giving 900 mg in like in 1 liter of 5% dextrose or NaCl for like 24 hours. It's a prolonged infusion we will give. So that's about TLS.
In case if the uric acid reduces, okay, there was one patient, even though the patient's uric acid level is 6.4, they started giving allopurinol. When I asked the doctor, he was like, because of his having tumor, like lymphoma was there. So in case it will increase, that's the reason the prophylaxis are giving. But his uric acid level went from 6.4 to 2. Is it necessary to still continue the drug? They'll
also for like uric acid for another 1-2 days. If it's you see the pattern when it's decreasing.
It's suddenly like
now 2 days. One more day they'll observe. If it's decreasing, you can recommend directly. It's like it's decreasing, you can like withhold. But that's why they're saying like 3 to 7 days and everything. In between that day, if it's getting reduced, will continue. But there's a chance that once when you like they might reduce the dose. You can tell for dose reduction, means if it's TID, you can tell for like BD you can make it. Or the reason is like once when you stop it, it might can increase because TLS won't happen at one day. It will happen within 4 or 5 days of the treatment. So in that cases, it can, when you stop it, it can rise up again.
This should be continued until the chemotherapy drugs has been given.
Yeah, up to 7 days after the chemotherapy also. Means today if I'm taking chemotherapy, up to day 1 or day 2 only they'll start. And like depending on how severe it is, they'll continue till 7 days for allopurinol, and febuxostat is 14 days. In cardiac cases, you won't give this one. The more cardiovascular complications are there in febuxostat. Mostly they have seen allopurinol, they'll start.
So this lysis occurs because of chemotherapy or?
Chemotherapy also it will,
malignancy.
malignancy, when it's increasing, tumor is increasing also it will break after a point. And like some more conditions were there, like even glucocorticoid therapies also, or any MAPs when you give, rituximab or like any monoclonal antibodies when you give, that cases also it will break. Fludarabine, this chemotherapies also. Whichever cytotoxic agents we are giving, they'll break. Any other roasts?
For hypocalcemia, is there any tablet?
Yeah, you can Shellcal, you can use. Shellcal, these things, vitamin D tablets also are there. Yeah, you can use. Shellcal I have seen use. Syrup, some Shellcal, some syrup will be there based on that. Mostly you'll give one vitamin D I have seen, they are given. Then they'll check, keep on checking weekly once they'll be checking anything. Vitamin D, like that calcitonin levels and everything. Once to monitor like.